Good morning, everybody. Nice to see everybody this morning. Welcome to Grand Rounds. Happy Halloween. It's my privilege to introduce our speaker this morning, Dr. Elisa Siegel. Dr. Segal is the Senior Clinical Solutions Medical Director for National Aetna Medicaid. She's board certified in family medicine, and she's been leading the Joint Opioid Initiative, a prescription for change, since 2016. She is the author of the white paper, A Prescription for Change, and the booklets, If at First You Don't Prescribe and Power Over Pain, which are being used as part of a larger academic detailing and marketing plan for Aetna. She's been a featured speaker and panel participant at multiple statewide and national summits, as well as an active member of the Arizona Governor's Goal Council and the statewide task force on opioids. Her topic this morning is Changing the Conversation, the Myth of the Magic Pill. Please welcome Dr. Siegel.
Thank you for that very lovely introduction. My name is Elisa Siegel, and I'd like to thank Dr. Potker for inviting me here today. Our sons have known each other since kindergarten when I got called to the playground because my son had thrown another kid's glasses into the sand, and the rest is history. They're now college roommates. So, so thanks for inviting me, and I want you to raise your hands if you've ever been a patient. Now keep your hand up if you've ever been prescribed an opioid for pain. Now keep it up if the person who prescribed it for you talked to you about the risks, side effects, or gave you other options. Now put your hand back up if you saved the leftovers for later, just in case. Be honest. Okay, now doctors, including residents, because you're doctors, physician's assistants, nurse practitioners, raise your hands. Keep your hand up if you've ever prescribed an opioid for pain. Now keep it up if you've ever had any formal training in pain management. See, the thing is, most if not all of what we think we know about treating pain we learned from salesmen and agents of salesmen, CME. There's no training, as you know, in medical school on how to manage pain. Yet pain is the #1 reason people go see a doctor. And I don't know about you, but I never even thought twice about it. The patients came in with pain. You had different pain medicines you could pick from. You had Dilaudid, Demerol, Vicodin, Percocet. You just picked one, and that was the end of it. We never thought about that there was a difference between nerve pain, bone pain, muscle pain. So we learned from each other, from the attendings we did rounds with, from our colleagues, from the drug reps that came to our offices, and from CME, which I'll talk about in a little while. First, I want to make one point before we get started. Everything that we do in medicine is supposed to be based on evidence. The evidence shows that opioids are less effective, or at least no more effective than non-opioids for treating pain, yet we continue to use them first line. So what qualifies me to be speaking about opioids in the first place? For about 16 years of my clinical years in family practice, I did urgent care. So I saw a lot of pain, real pain and fake pain, drug seeking. And I treated it all wrong, just like most of us did. Also in the last 5 or 6 years, I have been a patient. I had my left kidney rebuilt by a Da Vinci robot, and I had my appendix and 11 centimeters of colon removed. And I can tell you firsthand that IV Toradol worked better for my pain than the IV Dilaudid they kept trying to push on me. But it was really hard to get them to stop trying to push it on me. And if I hadn't known there was such a thing as Toradol and asked for it, I wouldn't have gotten it. So those of you who are Apple fans will recognize this picture behind me as Steve Jobs pulling a MacBook Air out of a manila envelope. This is what he used to call the star moment. The moment when the audience would all go, ooh, ah, something different, something that breaks the mold. In the business world, that's called disruption, and that's going to become important in a minute. So for the last few years, we've been asked to sign the Surgeon General's Turn the Tide pledge to prescribe fewer opioids. We've gotten CDC guidelines that came out in 2016. And legislation now, kind of a little bit in desperation because we don't know what else to do. And even though prescribing has gone down 22% between 2013 and 2017, more people are dying. So why? I propose it's because we forgot the most important piece, the piece without which none of this is going to work, but it's the piece that drug companies like Purdue and others did not forget, and that's the consumer. So the supply, which is us, we created the demand. We were taught by savvy marketers how to manage pain, and we passed that expectation of opioids along to our patients. So why are we surprised when people are so afraid of the idea that we're going to take these away from them? No offense for the Denny's in the room, but how many of you have called up your friends on a Wednesday night and said, hey, you guys, let's go to Denny's on Saturday. I'll get on open table, I'll make a reservation for 6, and we'll meet at 8. Nobody does that because nobody plans to go to Denny's. You end up at Denny's. It's the same thing with people on opioids. You get prescribed something by your doctor, and you take it because that's what you're supposed to do. And then you end up down a road you might not have expected to end up. I didn't make that up, by the way. I heard that from a comedian years ago, and I thought it was such a great line, so I'm giving credit. I don't know his name, though. Okay, so here's some of the issues. From a doctor's perspective, like I told you, and like you already know, we have no formal training in pain management. So now there's a 3-hour mandate for opioid-related education, which you probably know in order to renew your license. So it's opioid education, but it's not pain management education, and it's only 3 hours. So I think it's kind of like a gesture, but I don't really think that's going to do what we're hoping it's going to do. Then, as you know, depending on where you work, in an office or in an ER or urgent care, there's time constraints. If you have an office, you have 15 minutes for a visit. That's what the HMOs allow. You don't call them HMOs anymore, but that's what you're allowed, 15 minutes. By the time you get the person in the room and start talking to them, it's almost the 15 minutes up. So it takes a long time to have that conversation, to open that door, and you know that once you do, it's going to put your schedule behind. You don't want to do that. Same thing in urgent care, ER. There's people waiting in the waiting room. They're sticking their heads in the doors. When's it my turn? So it's just easier to write the prescription. Then patient satisfactions were tied to bonuses in the hospital. If you didn't get the little smiley faces for how well you managed pain, the hospital didn't get federal money for those patients. So alternative treatments not covered by insurance, things like acupuncture, chiropractic care. Those are things we're actually working on to try and get covered now. There's an expectation that people should have zero pain. Zero pain is called anesthesia. Pain management is not zero pain, but we and patients both believe that this is the goal. Then a lot of people have unrecognized PTSD and are self-treating with opioids. They work really well, but obviously there's other problems. And then why should I change? What's in it for me? It's just fine the way it is, just don't rock the boat. Then from the patient perspective, there's this perception that if you believe I have real pain, not just, a paper cut, you'll give me an opioid. I mean, I waited 2 weeks for this appointment. I trekked all the way down here. You're going to tell me to take Motrin? Either you didn't believe me or you have some kind of other issue. Then they don't question the provider. Your doctor tells you to do it, so you do it. Some people come to us, they're already dependent or addicted, and that's a whole other issue. There's also a stigma attached to seeking treatment. So if you want to get help, you don't want to tell your boss, sorry, I'm going to be late on Wednesdays because that's my day I see my MAT provider, which is medication-assisted treatment, methadone clinics and Suboxone, or I'm going to an AA meeting. It's just easier to hide it, sweep it under the rug, and go on and function. Then there's the insurance company issue. By the way, I have no... what's that one? I have nothing to reveal in terms of conflicts of interest, even though I work for Aetna. Aetna has nothing to do with what I'm saying, just so you know. So insurance coverage for medication-assisted treatment is different depending whether you're commercial insurance or Medicaid. It might not be covered, and the drug might actually be cheaper than the treatment. And then again, they share that same expectation that we've passed on of zero pain. You may have heard the statistic that Americans use 99% of the world's supply of opioids. That's an acculturation issue. That's what we have taught people to expect. I'm sure other countries, people don't have less pain. It's just that that's not how they've come to expect pain to be managed. So there's this concept in America that I want it now and I don't want to have to do anything to get it. Except for the last one, the little blue pill. There is no such thing as a magic pill. Yet we keep looking for it. With people with chronic pain, you know, someone weighs 350 pounds and they have knee pain and back pain. There's not going to be a perfect, you're going to find just that right medication. You're going to have to talk to them about losing weight. And you can't just say to someone, oh, you need to lose 100 pounds, 200 pounds. You have to be able to refer them to someone who can help them and know how to do that. They might need physical therapy. In any case, they're going to have to put in some work because there's never going to be a magic cocktail. I almost never give this talk without getting a question about medical marijuana. To my view, it's just still the search for the next magic thing, and there is no magic thing. The expectation of the magic pill needs to change on both sides. The provider, who still, I know there are some of us who will still think that this is all kind of going to blow over, it's a big deal, but it's not as big of a deal as we're making it. But I have to tell you that's not true. So here's the dirty little secret. The dirty little secret is there's little to no evidence that opioids work well for acute or chronic pain. And I'll give you a few illustrations and a few studies. The first is called the SPACE study. This was done with 240 veterans at the Minneapolis VA with chronic osteoarthritis and or back pain. They were divided into two groups. One received 400 milligrams of ibuprofen plus 1,000 milligrams of Tylenol, acetaminophen. The other group got Percocet or Vicodin 5 milligrams with acetaminophen. At the end of the study, those in the non-opioid group rated their pain relief as better with fewer side effects. That was presented at the Society for General Internal Medicine conference in April of 2017 in Washington, D.C. The next was the Bronx Emergency Department study. This was 2 emergency departments in New York, 416 patients coming in with acute, moderate to severe pain, extremity pain, like fractures. They were divided, same thing, into 2 groups, opioid versus ibuprofen plus acetaminophen group, and at 2 hours after their dose, they were rechecked. There was no difference in pain relief between the 2 groups. That one was published in JAMA in 2017. Then there was, at the Portland VA, 551 patients surveyed who had been on chronic opioids for non-cancer pain, said that their pain did not get worse, but actually stayed similar or even slightly improved after stopping opioids. That was published in the journal Pain this year. There are over 53 unique studies that show that opioids do not significantly improve function or pain over placebo. So how many of you have seen this stuff published in Time magazine, like on the cover, or on your local news, or anywhere for that matter? Right, because it was presented at a medical meeting, published in medical journals, but never publicized. People don't read medical journals, and they don't go to medical meetings. So how are they supposed to know this? To me, it's like a conspiracy of silence, and I don't understand exactly why. I'll get a little more why the dirty kind of connotation for me. So put another way, 20% of people given 15 milligrams of oxycodone, which is a big dose, get 50% pain relief versus 65% of people given 1 Advil plus 1 Tylenol. So you're probably thinking, okay, she's telling me about studies, okay. What about real life? So if you don't believe studies, this is my Facebook page. I posted this stuff that I just showed you 2 different days, and I had over 30 comments, all like this, all positive. I didn't put anyone up to this. You know, Facebook, half the people aren't your real friends anyway. They're just people who just like, you remember vaguely from high school. So the last one is my dentist. If you still need more convincing, this is an excerpt from a text that a friend of mine sent. So remember I told you about my surgery with the dilaudid? The last surgery I had was 2 years ago. This was just a few months ago, and my friend had a major gynecologic procedure, and she said all they would give her in the hospital was Vicodin or morphine. She asked for Motrin, and they said no. She didn't get pain relief until she got home and took an 800 milligram Motrin. Then, even more recently, my mother had a lumpectomy, and when we were doing the pre-op, ready to go in, the doctor came and talked to us about what she was going to get afterward for pain. And she said, so, what do you like for pain? We have Percocet, Vicodin. I mean, she started rattling it off like it was a dessert menu. And I couldn't believe myself, but I knew my mother would be really pissed if I said anything, so I kept my mouth shut, but I'm like grinding my teeth together because it's still happening. And I don't understand why. My son, who I was mentioning in the beginning, had his wisdom teeth out a few years ago, and the oral surgeon prescribed 40 Vicodin for him. They gave me the prescription before he even had the surgery. When I scheduled it is when they gave it to me. 40 Vicodin. I could have never shown up for the surgery and kept it all for myself. I could have, I don't understand why 40 in the first place, but I found a few of these Vicodin in his drawer after I had taken them away, that he had squirreled away. Why are we introducing kids to their first high when they have their wisdom teeth out? I just showed you what all the evidence says about the fact that opioids are not as effective as non-opioids, but we're still doing it. So most of you know about first fill limits. Do you guys know? No? Oh, no? Okay. So in Arizona, as of January, actually before January, it was a 7-day limit that you were allowed to prescribe for someone first fill. And first fill was defined, at least in our health plan, by someone who hadn't filled a prescription for an opioid in 60 days. So you're kind of like an opioid virgin. And we had claims data, so we would know that. But you can look on the CSPMP, the prescribing monitoring program in Arizona, and you can see when your patients have filled prescriptions, so you know. So if you have someone who is not opioid savvy or opioid virgin, they come to you with acute pain, you can only write a 5-day prescription unless they meet an exception. And there's a list of exceptions on the Access website. Where this comes from is this graph that you see behind me. And what it shows is that at 5 days, your risk of still being on an opioid at 1 year and 3 years later exponentially rises. But you can see right from the beginning it starts to go up. So if we know that opioids are not the most effective treatment, why are we focusing on the number of days or the number of pills or the MEDs, morphine equivalent dose, milligrams? Why are we not focusing on the evidence? Okay, just makes me, okay, so here's a little story that some of you may have heard of. You heard of the Sackler brothers, Arthur Sackler? This is on the cover of a big magazine. This one actually was a big cover article. Arthur Sackler was a psychiatrist who was also a part-time copywriter to put himself through med school. In 1952, he bought a company called Purdue Frederick. And at the time, their medications consisted of laxatives, an earwax dissolver, and what they called miracle drugs, which are like antibiotics and steroids. Arthur made up testimonies from doctors for his advertising, and he was so successful that in 1963, Hoffman LaRoche approached him to market their new drug, Valium. They already had a drug called Librium, so they needed to somehow differentiate Valium. So what he did was he hired a bunch of guys called detail men, which were the fathers of modern drug reps, and he took out big color advertorials. They were like 2-page color spreads in JAMA. They had booths at medical conventions. They had 30-day free supplies given to the doctors. And the most important thing that he did was market directly to the public. This was the time of Vietnam when mothers were worried about their sons off at war. And so they labeled Valium for this indication called psychic tension. Psychic tension could be anything from like GI upset to restless legs to actual anxiety, and Valium was supposed to cure it. Valium became the first billion-dollar drug, and Arthur Sackler became one of the first inductees into the Medical Advertising Hall of Fame, which I bet you didn't know existed. Okay, so back in the UK, the UK division of, this is hard to remember, so the UK division of Purdue called Knapp Pharma was working on a drug called MS-Contin. It was for patients with cancer, and it came out in the UK in '81, and it came to the US in '87. During this time, there was a very important thing happening, which was the publication of a very famous letter to the editor in the New England Journal of Medicine by Dr. Herschel Jick and his assistant Jane Porter. This letter consisted of 11 lines, and it was an account of 11,882 patients at Boston University Medical Center who had received at least one dose of an opioid during their hospital stay for pain. They concluded that less than 1% of people who got that dose became addicted. This was a time when you didn't get a prescription to go home. You just got what you got in the hospital. So the conclusion was less than 1% of people given opioids become addicted. This was taken and they ran with it. This has been cited over 900 times. It was used in CME by a guy named Russell Portnoy, who used to do a lot of talking around the country. I was told this by drug reps who came to my office. This was clearly not a scientific study and not a really valid conclusion, but it's very important. It's called the letter that may have started the opioid epidemic. Then, back to Purdue, in 1995, OxyContin was FDA approved. It came to market in 1996. And because MS-Contin had this stigma of being attached to cancer, they had to, again, differentiate it. So what they did was they had a website. You could go on and get a 30-day free supply. You could find a list of doctors who would give it to you. They had a campaign featuring a guy named Johnny Sullivan, who was seen operating construction equipment, and he said that because of OxyContin, he was able to function again where he hadn't been able to before. Johnny Sullivan died at the age of 52 after flipping his truck under the influence of OxyContin, and when his widow was interviewed, she said he had been addicted for years. I have to look at this to make sure I didn't, oh, okay. So they also marketed it as first line. And they said that in the packaging, said that it was not as addictive as short-acting because of the sustained release formula. There was no evidence to support this, but the FDA allowed it to be labeled such. The FDA reviewer who reviewed it, a year after it came to market, quit. After a brief stint at another drug company, went to work for Purdue. So you're starting to see the little web that I'm weaving. The American Pain Society has been funded by millions of dollars from Purdue. The American Pain Societies who attached the emotional aspect to pain as a sacred right and had it declared the fifth vital sign in 1996. I know you've all heard that one. 1996, coincidentally or not, is the year that OxyContin came to market. They were giving rebates. I'm going to look at this because there's so much. Rebates to wholesalers for keeping it off the prior auth list. Refunds to pharmacists. They donated to senators and congressmen on key committees. Finally, and in between that, JCO in 2001, of course, mandated the treatment of pain for federal funding, and the DEA agreed to adopt what they called a balanced policy, which means we'll look the other way, because I remember this. Well, I'm afraid to write this. What if the DEA comes after me? They go, we won't come after you, don't worry. We're all on board with the same thing. So sales were about $1 billion a year at that point. And then finally, in 2007, there was a successful settlement of a lawsuit, $630 million against Purdue, which is a drop in the bucket compared to $1 billion a year of income. They were able to negotiate a settlement where they could not be prosecuted for anything that had occurred before 2007. But in the documents that came out during the proceedings, it was discovered that Purdue knew about abuse as early as 1998. They had been monitoring internet chat rooms where people were talking about crushing it and snorting it. And OxyContin was great for that because it comes in 20, 40, 60, 80, and very briefly they had 160 milligrams. So, a lot more than what we can get a 5, 10, 15 milligram dose for regular oxycodone. So they finally this year agreed to cut the sales force in half and stop marketing to doctors. And their new drugs are an abuse deterrent formula because the patent's up anyway, got to make something new. And Symproic, which is for opioid-induced constipation. So are they bad guys? Are they villains? Well, yeah, of course they are. But my question is, where were our medical societies and our medical education to counteract the propaganda we were being sold? Why did we never get any information to debunk what we were being told? That's something to think about. Okay, so some things that we're doing in Arizona. This is a booklet I wrote called, I don't remember what it's called, If at First You Don't Prescribe. And this is used in something called academic detailing, which is kind of like what drug reps do, but the product instead of a drug is information. So we would find these doctors based on what we call the monthly MED list that we would get from our pharmacy benefit manager. So we'd know who was prescribing the high doses, and we would make a phone call, make an appointment, go out to talk to them. And it wasn't like I'm not giving them a lecture like I'm doing here or even a talk. Just go out and say, hey, Dr. Jones, tell me about your patients. Tell me about what kind of barriers you're having, what kind of issues, how we can help. And sometimes we would discover, people are on 270 MEDs, but maybe when they inherited that patient, they were on 360 and they're on their way down. So you have to take everything in context. But it's a two-way conversation, and in that way we learn a lot about what the issues are in the community and what we can maybe do to help. The most important thing, the thing that I'm most proud of, is this booklet, which I have some here if you want them. It's called Power Over Pain. And this is created for a few reasons. So remember I said, you're busy in your office, you get these 15-minute visits, or you're just trying to, keep on schedule. Having that conversation is really hard. So this is a tool you can either have in your waiting room for your patients to read while they're waiting to see you. You can have it in the exam room. There's always a wait in there. Or even after you've seen the patient, if you don't feel like they need opioids, you say, you know what? I don't really think an opioid's the best choice. I'm going to have my nurse come in and go over this with you. I'm just going to go real quick and see the patient in the next room, and I'll be back if you have questions. So it's a tool. Scare tactics like, just say no didn't work. Nancy Reagan, that was a failure. So the Pain News Network article I want to quote said, at a time when people are under siege, the AMA has made it clear they are hard-hearted towards suffering. That's because of all of the new restrictions being put on opioid prescribing. But that's not the case. That's what someone would say if they believe we're taking away the only thing that will be effective for their pain. But that's not what we're doing, and until we educate people about that, that pushback is not going to end. People listen to those who they can relate to. So someone who's maybe in recovery, you're more likely to listen to that person about what opioids can do. So we've enlisted, they're called peers. They're people who are successfully in recovery, and of course, you're never cured of opioid addiction. It's a process. It's day to day. But these people have been successfully in recovery for an extended period of time, and they're also formally trained in being what's called peers. We are engaging them into the ER setting, into inpatient, when we have people coming in maybe for sequelae of drug use, like cellulitis, osteomyelitis. You get spinal abscesses, all sorts of things from injecting heroin. And that's a great time to engage someone. They're a little bit afraid. Oh my gosh, something did happen as a result of what I did. So maybe it's time. Maybe it's not time for them to change. But if someone comes to speak to them in the hospital, gives them their information. You know, maybe you're not ready now. When you are ready, here's my number. Call me. I'll help you. I'll help you to get into treatment. Also, in skilled nursing facility settings, people are there for weeks and we're doing nothing. In fact, the skilled nursings are giving them opioids because it's just easier. We're taking, you know, it's the path of least resistance. I'm going to skip this slide. Okay, so the tipping point. The tipping point is that time when something seems like it's an overnight sensation. You know, it seems like the Beatles just like went on the Ed Sullivan Show and became overnight stars, but they had been playing in Hamburg, Germany, and little after-hours clubs for a long time. So, you know, that perception, all of the things that we've been doing, which haven't worked, it doesn't mean that we can't hit on that thing that finally takes off. We can change what we prescribe for our patients after a procedure. We can talk to them about what they'd like and about the risks and side effects. We can educate ourselves on how to treat pain rather than just, okay, prescribe less. Great, thanks, great advice. What am I supposed to do instead? What's the effective treatment for nerve pain, for bone pain? And learning that is really important, and educating the public. Putting together mass marketing, which is what we're doing with social media. We've created a series of videos using those peers, talking about their experiences, and having these kind of 20-second hits on YouTube, or having you know, videos that could play on a loop in the waiting room, at the urgent care, or in your office, are helpful to make it seem like, okay, this isn't just your opinion. This is something that's supported. This is something that's coming from evidence. So all those things are really important. And if you're sending your patients to a dentist for wisdom teeth extraction, talk to them about, you know, if they try and give you this, you need to tell them you don't want it. Because we're trying to change things, but the education of the public is the one thing that we haven't done. That's the missing link. That, I think, is the key to the whole castle. And we are the public, too. Even though we're doctors and nurse practitioners and PAs, you know, we still believe what we see in the media as well. And this is what our patients are seeing. So tell your friends, tell your colleagues, tell your hospital administrators, and let's end this. And I have time for questions. I have a lot of time for questions. I went fast. So let's talk. So tell me some of your experiences and questions. Yeah. Mm-hmm. So it depends. Just like everything, there's good and there's bad. There's terrific pain management groups that are adding psychological, like psychologists, to do what's called CBT. Do you guys know what that is? It's cognitive behavioral therapy. So the really good ones are taking a multidisciplinary approach. They're adding physical therapy, sometimes in their offices, sometimes they're closely related to physical therapy in the community and referring to them. But the way to manage pain really, it used to be back in the day before CBT codes and all that stuff, it used to be CPT codes. CBT is something else. That's our computer-based trainings that we do. So it used to be that those things were multidisciplinary. But because of CPT codes, they were broken out again and everything became, you know, disjointed. So it's important to find one that you like, that will give you feedback. If you send a patient, do they give you feedback? Do they call you to get history? Do they talk to you? If they don't, I would move on to another one, because we have a lot of them that are just kind of pill mills. I mean, for lack of a better word, they exist. And the only thing we can do is weed them out and not refer to them. Yeah. Yeah.
More legitimate reason in pediatrics to be especially aggressive.
Two things immediately leapt to mind when you said that. And the first one was, is it the patient's pain or the parent's perception of the patient's pain. So I think it's important, some parents, oh my God, he's crying, you have to stop it, you have to do something. So I think there's that danger of being so aggressive because of the parent, not necessarily because of the child. And then, what was the second thing? Well, depending on what you consider pediatrics. Do you consider it really small children, or are we including young teens in there? Because the 11, 12, 13-year-olds, I mean, there's stuff at school going on with drugs. So if we're introducing them, by the way, that 5-day first fill limit, that's 20 pills. That's, it's QID usually, 1 every 4 to 6 hours. There's a study where they actually tagged pain medication with some kind of, I don't know what they did, that would degrade it with stomach acid, and you could see how many pills your patient took after an acute procedure like a surgery. The average was 8. If you're sending someone home with 40 pills or 20 pills, that's 12 or 22 pills to be sitting, 32 pills, to be sitting in your medicine chest, to be taken by your kid to the party, to a contractor coming to your house, going through your medicine chest. Most deaths from opioids occur from other people's medication, not what's prescribed to you. So the first fill limit will I think, help with diversion, intended versus or non-intended, but not with initiation. That whole schoolyard drug pusher thing, hey kid, you want to try something? It's 1 pill, 2 pills. So I'm very concerned about starting kids on an opioid unless they absolutely need it and have failed other things. But we don't give them a chance to fail. We just say, you're going to have pain, you're going to need this. Well, why? Based on what? So that's that danger of just having that reflex reaction. Did that answer your question? Does anyone else want to answer that?
Only to say that pediatric pain management has changed drastically in my career. Because we, as pediatric residents, there were many circumstances we didn't use much pain management. I'm not saying which is right and which is wrong
Mhm.
here, but now pain management is used in a vastly expanded group of kids compared to 30, 35 years ago. I don't know what's right.
When you say we didn't use pain management, do you mean nothing, like no ibuprofen, or just nothing?
Nothing.
Well, obviously nothing, yeah.
Take an example.
Right,
Okay, that it was, babies, they're on ventilators, and
right.
they don't need pain management because they're babies, and they don't need much pain management. And we're going to do the circumcision.
Oh, yeah, I remember the screaming when I put the clamp on, they feel it. Yep, that's right.
Okay, so it's,
Uh-huh.
okay, you need to do an LD, just stick the needle in. You don't have to worry about any pain management.
I vividly remember what you're talking
So
about.
it's changed, and again, I can't comment on what's best. or try to
But I'm not saying no pain management. I'm saying there's like there's IV Tylenol. There's, that works really well. So there's other things, but we never consider them. IV Tylenol is expensive. Morphine's a lot cheaper. So there's that consideration too.
I do think this gets back to this common as pediatricians, look back historically, I think it was in the early 1980s, there was a very famous case of a baby in NICU in Maryland, and it was published in Pediatrics, where basically this baby had a PDA that was surgically ligated with no pain medicine, and the parents got very upset and published a letter about it that was published in Pediatrics, I believe, 83 or 84. So if you go back to
Yeah.
the early 80s, there were actually, surgical procedures done on babies without any anesthesia.
Yeah.
And then I just know in my training from the late 80s, early 90s, that it was really pushed on me. I remember doing a rotation in hematology in Boston with a lot of sickle cell patients.
Mhm.
And pain management was, heavily pushed, and the message I got was, you have to treat these patients' pain. I mean, they were in a lot of pain with their sickle cell crises,
Mhm.
but at the same time, I think we were creating a problem with addiction.
Mhm.
I know there were a lot of kids who came to the ED with sickle cell that kind of wondered, are they really in pain or not? But it was pushed on me by my attendings that you have to believe these patients are in pain. Don't deny it, because you don't know what they're going through. You don't know what they're feeling. So it's been very kind of difficult. I the public of the expectation of no pain, and then physicians kind of being under the gun to also say we want to treat the pain so that they have almost no pain or very little pain. And it still kind of happens now where if we look at CMS measures, one of the big measures, as you probably know, is when a patient comes into the ED, is how quickly is their pain controlled in the setting of this proxy measure called for an acute bone fracture. They use that as the measure of somebody's in pain and how quickly did they get treated.
Right.
Even if they don't have a bone fracture later, even if the x-ray is negative,
Yeah.
the idea is, when they came in with pain, how quickly were they treated in the ED for the pain. So, and then
But-
they're measured on box scores.
Mhm.
You have to have either a 9 or a 10 on your patient satisfaction survey. Even an
I
8 or a
know.
7 isn't good enough.
Yep.
We're all under the gun to get that top box score of a 9 or a 10 on
Right.
the CMS survey, whether it's Prestini or NRC
Uh-huh.
or whatever. So
Right.
I do think physicians get kind of mixed messages, and
They do.
but we have to kind of go this direction.
Well-
It takes time to explain. So
It does.
again, under time pressures to talk to patients
Uh-huh.
about what are their options for pain control rather than just,
That's why we treat colds with antibiotics.
rather
It
than
takes
just
too long to say no.
we have to somehow change our health
Uh-huh.
system so that we can take the time to explain things rather than just quickly writing a prescription and sending them out the door.
I agree, and that's why we're creating some things hopefully to help. But the fact, what you're talking about, doing surgery with that anesthesia is horrifying. I mean, nobody would ever suggest that. And I never say anything about, during the surgery, the patient needs to be asleep and not feel anything. I'm talking about after, and also I'm not saying don't manage pain. If someone comes in with sickle cell, I'm not saying don't treat it. What I'm saying is that the evidence shows that the way to treat it, or what treats it more effectively, is actually not the opioid. So it's not don't manage pain, don't give anything for pain at all. And I think some people still believe it's just Motrin, it's not going to work. There's no way, it's just Motrin. But really, evidence doesn't lie. In people who were in the studies, they rated their own pain. We didn't put that on them. And it does work. And again, there's IV forms of things like Toradol and Tylenol that work really, really well. And I'm living proof. Dilaudid did nothing for me other than make me gorky and sleepy. And sleeping patients don't ring call bells, so, but it didn't help my pain at all. The Toradol was the first time I got relief, and my friend, the first time she got relief was ibuprofen. So I'm not by any means saying don't treat pain. I'm saying we've been treating pain all wrong all this time. And it's hard to break old habits because you get these ingrained beliefs, but they're wrong. In the back. Mm-hmm. Right. Nope. Exactly right. Mm-hmm. Right. Right. Yeah. No, you're right. Mm-hmm. Right. No, you're right. And sometimes it's the placebo effect of getting something IV. So sometimes that's why, for the patient, they think it works better. But it works just as well enteral. You're right. You're absolutely right about that. Yeah.
That was a great talk.
Thanks.
I read a lot of this stuff.
Thank you.
I agree with what you said. Let's say somebody has job surgery, literally cut open, not laparoscopy, and gone through the hospital and all that stuff. Those people, is that kind of pain actually relieved on not on or is there actually a goal somewhere?
I was cut open for my appendix and colon removal. So I felt that it helped me. It doesn't mean it helps everyone. Everyone has different pain tolerance. But also, we're not talking about what's given in the hospital. I'm talking about more what's given when you go home. Because a few doses of, narcotic post-op is fine. There's no problem with that. But it's that bottle that they make you take. I said I didn't want it. Oh, no, you need to take it. You're going to have pain. Well, I don't want it. But you'll see. Trust me. You're going to have pain.
Yeah, I've had that happen.
Yeah. Mm-hmm. Yeah. 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 Not after abdominal surgery, though. Okay. Uh-huh. No. Mm-hmm. Right. For chronic pain, absolutely. Things like fibromyalgia, exercise is the best treatment. So yeah, definitely helps. Oh, I want to ask someone in the back. Can't hear you, sorry. Mm-hmm. Yeah. That's a great question, and I have to find out about that because I've been asked that before. And the question was for people with sickle cell, people with chronic pain who can't take ibuprofen or acetaminophen, then what then? And are there any working groups that are being convened to study those kinds of patients? And I'd have to look that information up, but that does come up. There are people with, gastric ulcers and inflammatory bowel disease who can't take these drugs, or liver disease, renal disease. So, there's definitely issues to consider, but everything has its downside, its upside. So I'll look into that. If you want to give me your information, I can let you know. Yep. Right. Right. That's right. And we didn't get here overnight, and it takes a long time. I used to wish that I could just, for 5 minutes, put myself into that person's body and feel like, if I had this pain, how bad would it be? Didn't you ever think that? I'm curious to know, is it just this person has no pain tolerance, or do they really, really have bad pain? And there's no way to know. People who came into urgent care for drug seeking were, number 1, migraines, number 2, back pain, and, broken teeth. There are people, broken tooth is worth a fortune on the street. If you have a broken tooth, that person can go from dentist to urgent care, collecting narcotics and then sell it. And so, it's a gold mine. And same thing with migraines. You can't prove someone doesn't have severe pain, and you give them, we used to give them Dilaudid, we used to give them Demerol, whatever, and then recheck them. Oh, I still have pain. I still have pain. Well, who knew? And you can't not manage your pain. I mean, I know that these things are very real. I'm not trying to paint a picture that, like, here's the answer and it's all this beautiful fairy tale of what we should do, because we're living in the real world and these are real world things that we see. But I'm just saying to have this in your mind and start thinking about everything in the context of, do I believe that an opioid is the best treatment for pain? Do I really believe that non-opioids are as effective, or at least as effective, or at least the opioids are no more effective? So if you believe that, you'll start to at least consider in the people that don't fall into these kind of outlier situations, what you're doing as a general practice day to day in your management of pain. But there are those times, in the ER especially, and, the back pains, nothing on the x-ray. Oh, but my leg, you don't even know. I can't even function. It's hard. Yeah. Oh, sure. There's CME all over the place in pain management, but again, you have to make sure you're getting reputable CME. So there's a website. I don't have the name of it, but I can get it to you. There's several websites with free CME about this, and there's some societies like the Physicians for the Responsible Opioid Prescribing, PROP, that have information. Jerry Avorn at Harvard, who was a creator of academic detailing, their NARCAD website has a lot of information. So there's definitely education out there. And, unfortunately now what happens with pain management is procedures. Okay, we're not going to write opioids, but we're going to do more blocks, and you're going to cover them, because insurance didn't used to cover blocks until you failed medication. And failing medication included opioids. So we finally took that away so you can do the blocks, and that's where the money is anyway, because they would have their nurse practitioners and their PAs writing the prescriptions while they were doing the medial branch blocks and the facet joint injections and radiofrequency ablation. So it's medicine isn't not as beautiful and rosy as it's painted on TV, as we know. There's no one-size-fits-all solution to anything. It's all case by case and clinical experience and knowledge and applied knowledge.
So,
Yeah. Mm-hmm. Right. Mm-hmm. And that's okay, but they should have an option. It shouldn't be, this is what you get and that's it. If this is what you want, fine, but you're not going to get the 40 pills when you go home, but yeah. Mm-hmm. Right. That's true too. Bye, guys. Right. And that's okay for short term too, but again, not having an option is my issue. This is what you get. This is what's on the orders. I have a pre-printed sheet here. I'm going to check off the stuff that's on the pre-printed sheet. I'm not going to think what you need. We used to have post-op orders. Do you remember, like in residency? You check off the Demerol and the Visceral, and everyone got the same thing and pretty much the same dose, unless they were really skinny or really huge. They got the same stuff. And we never thought about it. Never even occurred to me to think, what am I doing? Thank you all for coming. I learned a lot today too, so thank you.